What's up, everyone? We are live, Critical Care Lounge. What's up, Adam? You look a little sad today.
You're starting off with the Eagles jokes to begin with, aren't you?
I got to go right for the jugular.
Yeah, that's right. That's right. I'm okay, man. I was looking for a good game, and it all up into the last 2 minutes, I think it satisfied me. But it was
I It was a good game as far as Super Bowls go. It wasn't the outcome that we wanted, but it was a good game, and
mhm.
I think people look back at it as being like a great Super Bowl. Again, not the results that we wanted.
Yeah.
We were
But I
talking
know
earlier.
you watched for the halftime show, didn't you? That's why
Oh,
you really watched.
come on, Rihanna. Like, that's the only thing my kids want to watch. The whole game they were talking. I was like, guys, just shut up. And then all they wanted to do, when Rihanna came on, I started talking. They're like, Dad, Rihanna's performing. Have some respect. She's all right. Okay, jeez. That's how it is in the
That's
household.
hilarious.
Only guy, only male. That's what happens when you're the only male in the house. But it's good to see you, Adam, and good to see all of you here. We have a bunch of people on today. Adam, we have a very special guest today, don't we?
Yeah, I think we don't admit it, but we all have our oncology speed dial. Like if you're in the hospital and you need an oncologist, you call the same person regardless if they're on call or not. So this is my cardiology, interventional cardiology go-to. So I'm really excited. We have Dr. Leo Iliadis coming on. He's an interventionalist, and if you look him up on the website, he's got a whole bunch of titles. But he's more than anything. Just a good guy, and I'm really excited to learn from him.
Thank you guys for having me here today. That was very gracious, Adam. Appreciate that. I was not crying either yesterday, Annie. So
Yeah, I should I should also say you're the only cardiologist who answers my phone call, so that's by default I call you. But
I understand. I understand. Sure, this is a great, guys. No, great experience. Thank you for doing this. This is the modern education, as we talked about. So this is cool.
yeah, yeah. So let's see what we're talking about. So I think and I think there's some joke here about Valentine's Day being tomorrow and talking about the heart, right? That I'm sure Haney's got a clever saying up his sleeve. But I want to talk about acute pulmonary embolism, and I think the conversation naturally is going to go to mechanical thrombectomy, as you see the title. But before we get there, I'm hoping we kind of talk a little bit about how we classify PE, how we look about PE, how we think about PE, and maybe even some of the history of treatment of acute pulmonary embolism. Um, so, should we? I guess let's just jump into it. Is that okay, Haney?
Let's
Yeah.
do it.
So first, let's just do that. Tell me about the types of PE. Like we hear terms like acute versus subacute versus chronic. We hear things like massive, submassive. How does the interventional cardiologist think about pulmonary embolism?
So with respect to it's all acute because based on symptoms. So chronic is something that's greater than I would say greater than 3 months, 4 months, but there's no classification of chronic. Chronic is something that's turned into pulmonary hypertension later on. So with respect to risk stratification, we look at someone who has a low risk, which is greater than 70% of the PEs as being hemodynamically unstable or stable. Echo is fine, cardiac markers are fine, and the patients had some event that we recognize, but all their markers suggest they're going to do absolutely well, and that is the largest proportion of patients, and thankfully it's a very safe way to safe outcome for some of these people. We in interventional cardiology started looking at some of those patients who were the sicker of those groups. So they give them this classification of submassive. So submassive means that you have a PESI score, pulmonary embolism severity index score of class 3 or greater. So that's defined by heart rate, defined by at presentation. I always say that to the trainees and everyone. At presentation is really where you're making this decision because the PESI score was defined at presentation. So that's your clinical data. Their history, their objective measures, which is heart rate, blood pressure, oxygen saturation, end organ perfusion, specifically the brain. So the PESI score, then you're looking at objective measures such as troponins, their blood tests, their BMP, other BMP, and then an objective measure, which is their echo. So if you have what's considered a highest risk patient or a massive PE is someone who's hypotensive despite medical therapy, despite fluids. That's considered massive pulmonary embolism, and those patients get, a treatment course which can include ECMO and extraction, can include lytic therapy, but those are the very, very sick, and thankfully a very small percentage. So what does that
So
left us? 70% are fine, 5% are very sick, and then 20, 25, 30% are the submassive category.
that's great. There's so much to
It's kind of
unfold
good.
there. And where do we start? Haney, I want you to ask a question next, but let me do one first, and it's PESI score. And
Mhm,
I will admit I was a fan of the PESI score until I really looked at it. And
mhm,
it's designed to predict mortality, like it's something like 3 or 6 months. It's
correct.
something like that, right? Which I'm going to tell you the truth, seems a little crazy that I'm basing acute treatment on that. And I was even using it to dispo patients, whether it was the acute
Mhm,
floor, the medical floor, or the step down unit or the ICU. And it seems, I don't know, it just seems off. And I know that there's a lot of critics of the PESI score and that it should not be used in the acute setting. I don't know.
yep. No, no, Adam, you're spot on correct. But for us at the point of care, what else do we have to help
Yeah,
risk stratify these people? Who's calling me on the phone? So tell me about the patient. So I'm trying to calculate
yeah.
that number in my head and say this is someone I should look at. This is someone who's going to do well no matter what I do to them. We now that we're embarking on this as an interventional, quick care, as a pulmonary community, we should relook at risk models. How can we
Hmm.
clinically risk model these people? And so we bastardized, and that's what I called it. We looked at PESI scores at admission, and then PESI scores pre-discharge. Right, we did that analysis, just trying to show a clinical difference in these people after an intervention, whatever that may be, including medical therapy. So again, I use that as a research tool to sort of spur on interest and say, this is imperfect, completely imperfect, but let's think of this a little deeper and figure out something else that we can use.
Maybe it winds up being that you look at the PESI score, and then there's some elements of it that will wind up being the ones that predict acute deterioration. Because I agree with Adam. All we care about when these patients show up to us is who's going to decompensate in the first 24 to 48 hours. Those are the people, I think, if you look at the PIOPED stuff that came out, it's not long-term
Hmm.
outcomes that we care about anymore. It's who's going to decompensate in front of us. Who do we need to act on quickly? So perhaps it'll be something that we look at prospectively and see if there's a data set that we can find there.
Agreed.
But
Agreed. I mean, they're getting enough data from all the registry studies that we're all participating in
yeah,
that because we're looking at this massive, submassive category to say, you're right, these are the sick people. The well ones are going to do fine no
yeah,
matter what we do.
and it's also cool because I remember that there was a time where these were the intermediate risk people were really hard to find
Mm,
because we just didn't have the registry set up. If you had
Great.
them, then you entered them into study. But now that we're actually identifying people, I think that there's in the next 5 years we'll probably get a little bit more granular and
Mm,
get some more answers.
Completely agree. And then, we're starting to risk stratify.
Hmm.
So use PESI or don't, but look at the patient, right? At the bedside, somebody's tachycardic, hypoxic, increased oxygen requirement. That's somebody who's sick.
Yeah.
And then, the only objective measures we had in cardiology were clot burden, which is a modified Miller scale, which the radiologists poo-poo, but and I think they're right. But at the same token, we need some assessment of clot burden, and then the echocardiogram. So is the right heart straining? Is it not? Goldhaber from Harvard says if you have right heart strain, you should do something. He was a big advocate for it, and that's kind of driven the field forward to look for something that can improve our RV strain.
And that guy has a gigantic textbook, right? So
Yes,
I
he
mean, you
does.
got to listen to that. I mean, you got
It,
to listen to
it's
that guy.
it's over there, right there.
Yeah, it's propping up my laptop right here as we speak. So it's very useful.
Absolutely true.
All
Absolutely
right.
true.
So let's go back to you get the call. You're
Okay.
like a specialist, right? You're like the SEAL Team 6. There, you're waiting, you're always ready. And then when you get the call from one of us in the middle of the night and we call you and say, hey, there's someone with an intermediate risk here or massive that's stable but can't really get lytics, what are
Hmm.
some of the things that you ask the referring hospital or you ask of us so that you know whether or not you need to get in quickly or you have some time?
Well, as you said, there's somewhat the clinical parameters really trump everything. I've done whether the echo is terrible, the RV function is terrible or dilated or not. The is not it's relevant, but it's not in that very acute setting. It's not as germane. If you have the submassive that we need some decision making on, then I'm going to ask, where's the clots? Can I see them? We have tech now, Haney and Adam, that can help us in our regional pool look at the clot burden overall and see whether it's proximal, whether it's distal. So I'm going to ask you, what does the CAT scan look like? What is the RVLV ratio by CAT scan? Because that's readily available. They can actually do it at point of care. Tell me about the blood pressure. Tell me about the heart rate. Tell me about the oxygen saturations. Tell me what they look like after a liter of fluid. Because we're all, if the right heart is under strain, if they're having a fairly impressive PE, they're all dehydrated. They
Mm,
act more like an RV infarct than they do otherwise. And we've all seen that. You give them half a liter of fluid, and blood pressure is up, heart rate's down a little bit, and gives us an opportunity to kind of get more information, stabilize a little bit, and then send. Half dose lytics. We're going to talk about that. That's something to think about. In
yeah.
some of these people.
Well, let me ask you, just staying on that, if you receive the phone call, I'm trying to pick between one or two questions. Let me ask you this: how much do you strain in an assessment when you're not really sure whether or not this person, should get mechanical thrombectomy? Is it ever part of the equation, or is it still experimental at this point?
Still, I mean, there's some papers out there on RV strain, on echo strain, on 60 we talked about. So they're looking at some of these echocardiographic variables to help her stratify us. But since the expertise in some instances aren't there, so I will have them do an RV-LV ratio for me
Gotcha.
via the CAT scan because that's readily available. The Viz technology, which what Cooper is part of, is going to ultimately give me an LV-RV ratio. It's actually at point of care. And so as we toss this out to our network, we'll have point of care being able to show that to the surgeon, the operator, say, hey, look, this is what you have. This is somebody you should take soon.
I'm just gonna ask one question, then I'm hand it over to Adam. Do
Sure.
we use artificial intelligence at this point? I just have to ask that question because everyone's talking about artificial intelligence these
Yes, yes.
days.
Would you
So
like
should
to
we use
see? I can actually.
ChatGPT? Should we
Yeah,
ask ChatGPT? Is this
yeah,
person? Oh,
yeah.
oh, you
I have.
have.
We are at a beta, not a beta site per se, but because of our experience with neurology, Viz, artificial intelligence has given us, and we've been part of their Viz team, and this is has to see me first. Hold on. I'm not an advertisement for Viz, please, by any stretch. However, I can get, and I'm going to try and make this as compliant as I possibly can, but I get, I'm going to cover the name. I can get those. That's what I receive, being part of this network. I'm not sure if that comes across, Haney, but that's someone's PA outflow track that the computer, the point of care CT scan is done. It uploads to the Viz servers. An AI algorithm is run. They recognize as PE as possible PE, and it's sent down to us.
That's wild.
I was on call over the weekend, so I tapped a couple of times, and three out of four was spot on correct. The fourth had artifact, a little bit of artifact. I think it was overreading, but
That's
that
nuts.
alerted me that they're coming, and I did two cases today based on the Viz AI experience. So it's here. And that'll give us an opportunity. You can put in information, you can generate a PESI score for you. As we get another marker, perhaps it'll help generate that score. So it's exciting and it's here.
Sweet. Adam, what do you got?
So yeah, I think I'm going to give my opinion on submassive PE, and I'd love to hear your kind of
Sure.
reaction to it. And I think that one of the major reasons, and I hope you agree with me, is I have not seen a convincing study that tells me intervention needs to be done on the submassive PE. And that's whether it's lytics or
Mm,
whether it's mechanical thrombectomy or catheter-directed lytics or whatever you want to say. I think that for the most part, I just haven't seen anything that convinces me that I should do it. Yet, like physiologically, if there's a big P saddle PE, right, and there's spilling troponin, like we should do something. And I guess let's define what submassive PE is. Like at least what I was taught was that there's evidence of right heart strain, whether that's troponin spill, BMP spill, right heart strain on the echo, um, yet hemodynamic instability. And I think that's just too heterogeneous of a group. I don't know if you agree. I think about cardiogenic shock, for example.
Mhm.
We've all seen the patient that has a rising lactate, shock liver, creatinine's going up, yet their MAP is okay. And because it's not about MAP, it's about cardiac output. And I wonder if the same thought process should be done in the submassive group. There are patients that have preserved TAPSE and forward flow from the right ventricle that are submassive. There's patients that don't. And those should probably be divided because I think the treatment approach may be very different.
No, Adam's spot on. We need additional information to help risk stratify. So, with respect to no data, there's a lot of registry data. We're coming forward with randomized clinical data to see an outcome, to see, at Cooper today, we follow each and every pulmonary embolism. Everyone gets followed, and they get followed for 6 months, a year, as long as they're within our system. And I can tell you that, leaving the hospital, you've seen this, I've seen this, a clinical benefit in that submassive PE with troponin elevation, RV dysfunction, elevated PESI score. So I think there's a benefit at point of care, but I have seen at 30 days dramatic improvement in normalization of RV function. If you believe RV dysfunction is a long-term predictor of bad outcomes, and I think you're right in what you said, 100%, is that I don't have randomized data. I do not have randomized data, but I do, having been in this field since probably 2010, maybe 2008 when I graduated fellowship, that we have tried several technologies to address this, dissolving technologies and such. And more recently, the technology is helping us improve the RV function by extracting this obstructive clot, and therefore that's going to change outcomes. Here at Cooper, we're in Strike PE. Sorry to interrupt. Just which is really looking in the registry, which is doing that registry. We're also going to be in Storm PE, which is really asking your other question, which is this any better? It's a randomized trial of heparin and anticoagulation in submassive PE versus mechanical thrombectomy. So I think they're finally doing the right study that I've been asking them to do for 3 years to address
I
the
just
actually your question.
I liked what you did there because it was starting to get like a pro and con debate, and
Yeah.
you dropped the 2008, which was like when I was still in medical school or thinking about medical school, and you just like destroyed any argument I could potentially have. Like it was a very clever maneuver.
You
Yeah,
know, us
it's
Greeks
it's just like
go.
what is the outcome we care about, right?
So,
So like
well,
we look at RV dysfunction in 6 months, okay, but maybe it takes longer for the RV to remodel or for the clot to resorb. And, maybe it should be 12
mm,
months. Like, so I would be interested in oxygen use. I'd be interested in, a walk test. I'd be interested in functional measures because it's not going to be mortality. You're not
no,
going to find mortality benefit. And
no,
I think that's really hard.
it,
I
it
also
is.
think we should intervene on it. I'm very
Yep.
pro intervention, but I just think yeah, I don't know,
You're
Haney.
you're you're asking the questions that I ask every day. Is this the right patient we should be working on? Is this the right patient we should be offering all these expensive, the technologies for risk stratification? And happy to do it because I think they clinically get better. And I'm going to say this full disclosure. I did early on procedures because we're very safe. I'm touting our own success here. We're extremely safe because you're doing procedures on people who you think might do well no matter what you do, right? So I had to be very, very safe in
Hmm.
what we're doing, and we were. But proof of concept, you have to say, can I really use this technology to get rid of the clot, and then translate that to a longer term outcome? So we're, we're riding that line as a researcher, as a physician, as a clinician. I clinically want them to get better, and then I would like to see a nice long term outcome that says their RV's better, that their exercise tolerance is better. Strike PE is a 6-minute walk-based test, the one we're currently in. So I think they do one right before discharge, which is always hilarious because they, they can't make it up and down the halls. They've got IV poles and such in tow. And then 1 month and 6 months later, they're meeting me
Yeah,
out in the office, and they're very happy. I can tell you that clinically, these folks are happy to be feeling better.
yeah, that would be meaningful.
Yeah, I think so too.
Since we're talking about studies, could you give some insight into the studies that are happening or have happened with mechanical thrombectomy, well, versus just heparin, versus the studies that everyone really wants, which is mechanical thrombectomy versus slow infusion of TPA or some subdose of thrombolytic that would be equivalent. And for those of you who are listening who are not sure of what I'm saying, a lot of the studies that have shown positive benefit with mechanical thrombectomy are just against heparin. And so you could make the argument it's like, well, that's not an equivalent, that the control group was almost set up to fail because you had a superior therapy. The thing that people want to know is if you're using thrombolytics as part of your care, what would you do if you didn't have mechanical thrombectomy but gave an equivalent dose of thrombolytics versus the mechanical thrombectomy plus thrombolytics?
All right. So I'd have to go back to, this is hydrolyzer angiojet days, which were my first experience in pulmonary embolism treatment. I was taught by an interventional radiologist at the University of Michigan, and he really had some forethought on that we have to somehow address this clot, whether it's through extraction, through dissolution, through mechanical fragmentation. And those studies were, though I think the patients clinically did okay, they were fraught with lack of improvement from a long-term outcomes. Hence, in the early 2010s, 2013s, 2015s, there became this thought that perhaps the lytics could be utilized, and so a catheter-addressed lytic approach was catheter facilitated lytic approach was utilized, and Ultima. That's the ECOS trials out of Harvard, and they, as their own controls, showed an improvement in RVL ratio, showed an improvement in PA pressures. That was the first, and it was relatively safe. And that for me was extremely important because the prior set of trials that I even participated in, there was pulmonary hemorrhage, there was groin bleeding, it was really a fraught procedure fraught with complications. So marching forward with the Harvard group using the ECOS catheter, the thought was now can we address that clot without the use of low-dose thrombolytic therapy. And again, you're absolutely right. They competed against heparin, so beat up on old standard when you know that you're going to do well, and they were able to show a benefit. And I think that's safely what they were trying to do. The era of mechanical thrombectomy uh, came up in my experience, through serendipity. That was 2014. I'm at the American College of Cardiology. 2015 is when the trials were done and presented. I was sitting in our cath lab, which is next to the neuro suite, and here at Cooper. And I'm just one of those curious guys that I'm sorry. Cooper automatically logs us out if you're not on for a while. That I'm one of those curious guys that we're always interested in the neurospace. I do carotid stenting, and so I'm always reading the angiograms. And this company said, we have a larger bore device coming out that's currently utilized in the neurospace called the Penumbra. And I said, what is that all about? And he said, well, it's an extraction catheter, and you can extract. And we've actually done our pivotal first in man trial, and they did an extract trial, which is a larger registry, and we believe that this will be utilized in the space with outcomes of improvement RV function, clinical improvement, and then ultimately resolution of clot through repeat CT scan. They that was, to me, again, serendipity. You're having the right place, right time, drinking coffee next to the CEO kind of idea. And they said, would you utilize this technology? I said, let me talk to some thought experts, and I talked to a couple of other experts about their experience, and we started doing the mechanical extraction with that technology. We have others available as well. I can talk about them, but because we saw very similar PA pressure reduction, we saw immediate improvement, which ECOS provided, the catheter-directed thrombolytics provided, but it just took time. It just took a lot, 24 hours or so.
And the suction catheter, just for those who are listening at home, it involves no thrombolytics, right? You're just
No
extracting.
thrombolytics.
Right?
Correct.
Okay.
They're on heparin while they do the procedure, and we're very meticulous in where we place the catheters, and you turn on the suction, and it's just amazing. Literally, it's I did a case recently. It was 15 seconds. I was done extracting this clot in 15 seconds. It
So
was it actually struck me.
And I just want to give everyone an idea of just how excited Leo is and passionate Leo is about it, because the only 2 times Leo ever texts me is if the Sixers do something great or they make trade for someone like James Harden, or if he extracts a clot. And I just get these pictures on my phone that if you don't know what they are, you're just like, what is
What
this?
is
What's going on your
that? What
phone?
is that?
But Leo is extremely proud and always
Yeah, yeah.
presents, he
No,
brings the
I think
data.
it's good feedback. I want us all to be on the same page. I
Absolutely.
think that's what it is. It's you know, and I appreciate. I mean, Steve Akers was a huge naysayer to the concept of this, and because he said the data is scant, and I was like, Steve, 100%. But what I can prove to you that we're safe, and I can prove to you that I clinically get them better before discharge with both catheter-directed thrombolytics and you know if we wanted to go that route, and mechanical aspiration. We're fortunate we have an RI, which is also another a large bore device, great device, has a ability to give back the blood. There's an extraction of blood component of almost aspiration technology that we're trying to address, and Penumbra's done their techniques to address, and Nari does. And you know, Cooper's been great to us. They give us the AlphaVac if we really want to go crazy. So, so I have, and the
so
data unfortunately is not randomized. Data is registry series in expert hands.
so Leo, I'm gonna be honest. You know, when I call you, uh, I actually don't really care which device you use.
Right.
And I mean
You
that,
shouldn't.
and I mean that not to be funny, but you know, I think it's awesome that they get better. I think it's wonderful. I think it's cool when you send me the picture of all the clots. But you know, that's like an interventional. If we had a group of interventionalists sitting here, they'd probably be really into all the exact specifics and when you choose which one and when you don't. But in reality, I want to try to get a little bit more concrete. So first off, I think it's important to say for all of these patients that you're doing mechanical thrombectomy or suction thrombectomy, I've never seen you rush them to the cath lab. In fact, I've even heard you say that it helps to wait 24 or 48 hours for that clot to kind of become stiffer and well formed and less mushy. So I
That's
think
right.
that's important for everyone to
Mhm.
hear that
Sure.
listens to this. That it is important that they get to a center that can do it. Uh, but it's generally not the emergency at 2 in the morning.
Correct.
And I have a personal, and so what I really want to get into is who do we give systemic thrombolytics to? Because I have an opinion that I don't know if we give enough systemic thrombolytics. If you think about you know, codes, you know, CVAs, the dosing, I don't know the T and K dosing, but we'll stick with TPA, is something like I think it's zero point 0.9 mg per kg, and it ends up being 50 to 100 probably milligrams of TPA systemically. We do it all the time. So yet
Mm.
I've always been fascinated by that it's like in the stroke situation, we're pretty quick to do it. But I have found that in the acute PE, we're very hesitant. I don't know if you guys agree, if that's kind of your same experience.
Yeah.
So I do want to get into a little bit the hypotensive
Yes.
PE patient and how we approach it because I think that physiology is amazing. But
Right.
who should be getting TPA systemically that's not hypotensive? Like when are the times you say, please give TPA, and how much are you telling them to give?
So the my answer is yeah. We are giving more TPA at Cooper now than we've ever given. Right? Because I'm on the receiving end of those calls, and I'm telling them to give half dose, to give it, you know, to the unstables, of course. Hemodynamically stable, post 1 liter fluid. I base the decision based on the RV and based on clot location. If you have a central clot in the RV outflow tract, I'm very leery of leading those individuals. You know, that person's going to be next up with the next opportunity I get to the cath lab, but that is a very precarious situation. So it's driven by the anatomy of the clot, the CAT scan. The CAT scan is driving me to in a relatively stable patient to give thrombolytic therapy to that patient.
Now,
Um,
now this may be dumb. I'm sorry to interrupt. This may be dumb. If the clot is close or far, because if it's close, then you can do something about it. Or if it's
correct.
the unstable patient that's distal, are you more likely to give thrombolytics? Which population are you more likely to?
The large clot in the proximal area we
Oh,
can get to.
okay.
We can get to
No, I
the
know, but for systemic lytics.
systemic lytics. Yeah, I think both are well served. Proximally is the one that's better served. Just go flow
Okay.
dynamics, run by it. You'll actually get some dissolution. That's been my experience. When every time I give lytics here in my practices, when I'm consulted, I take them for an angiogram. Every single solitary one of them goes for an angiogram. And I think it's important to see clot resolution, whatever's there, we should really address. If, for example, and I've been very pleased with half dose lytics for that case you describe of somebody that I'm really concerned about. They have a huge clot burden, and I'm just uncomfortable leaving them till the next morning until I get them into the angio suite. I think Cooper should
Yeah.
give me my own angio suite. By the way, I'm just making a shameless plug for that.
Yeah, I agree. I think they should give you two. Um, so, yeah, no, I think that's good. So I'm thinking of a case I had recently, and I don't remember all the specifics, but she was, middle age, large saddle PE, was hypotensive at the outside hospital, got some fluid, came, normally hypertensive on 2 or 3 meds, came to us, heart rate 120, big central clot, MAP is 69 or something, heart, and systolic in the low 100s. To me, if she doesn't have any contraindications, that's someone who should be getting half dose lytics. Um,
Correct.
but by criteria is submassive, which by standard of care is just heparin alone, and then call you. I don't know. I just think it's really interesting, and I don't know what you guys think. Haney, what's your approach to lytics in the technically hemodynamically stable patient?
It's a tough one,
Case by
right?
case, yeah.
Well,
Case by case, yeah.
yeah, I mean, there that okay. So I don't think half dose is probably very, very safe. I mean, if you just look at the data, and like you said, if you look at the elderly people who come in who have a blood clot in a distal cerebral artery that get the full dose, and the numbers of people who bleed, which is not insignificant, but you take somebody who is younger, who has a clot that's localized in their pulmonary artery, who's concerning, and who's maybe that high risk intermediate. I have very little problem giving that person half dose TPA. There's literature also that says that you could also use your fibrinogen levels to serially dose
Mhm.
thrombolytics. So you don't have to
Correct.
commit to giving. I remember a case that I saw a few years ago where someone had a recent neurosurgical intervention, like within the past 3 months. And that person had a pretty high risk intermediate PE. At times, you could even call it massive, kind of dancing that line back and forth. And we decided to give quarter dose TPA as we were following the fibrinogen levels to make sure that we maintain good fibrinogen. And that person wound up getting 2 doses while we were serially echoing, and that person actually did okay. So
Oh,
I would like to start to see the studies where we either do the lower dose, 1 to 2 milligrams per hour, or maybe the smaller boluses, and then reassess rather than committing to the higher doses and saying, oops, we went too far. Or maybe
yeah.
there's a time that we personalize care. Maybe there's, an algorithm that puts in and says, this dose of TPA for this clot burden is going to put this person at some percentage of risk. And I hate to go there with, AI, but
Yeah.
those are the prediction models that we're going to be into in a few short years that are going to help us make these decisions.
Yep.
So to answer your question, someone comes in, they look a little bit unwell, and they have an intermediate risk PE. I don't have a problem giving those person 50 milligrams
Mm.
all day long and just watching that person. If the person's older or they have some comorbidities, maybe going to something like a quarter dose and then reevaluating before the next dose is given.
Just
Yeah, I believe
just to stir the pot. Sorry, just to stir the pot, Annie. The scientist in me would tell you that you're giving a suboptimal dose that's never been studied, so potentially not treating the PE at all, yet still exposing bleeding risks. So
Well,
But
I
we
don't
have
know the
small data.
answer, but
I think we have small data from Moffitt, right? That says that we gave 50, and the
no,
specifically the
25.
safety was it 25,
Mhm.
but specifically the safety
No,
was
I'm saying yeah.
very very positive.
yeah, I mean
Yeah,
for the quarter dose, you're absolutely correct. But there
right,
is data that looks at, and these are people who have looked at subgroup analyses and post
right,
hoc analyses that have looked at the bleeding incidence of people getting heparin, like standalone heparin versus half dose TPA, that show the bleeding risk is exactly the same. Quarter dose, it's been looked at in very small trials. So again, you're making. I wouldn't use that
right.
as a standard, but if someone has a recent neurosurgical intervention,
Yeah.
like what are we going to do? That would be a
Yep,
situation
I
where
agree.
you have to go off
Okay,
literature and make a personalized care plan. But for everybody else,
correct.
the bleeding risk for thrombolytic at half dose is, best accounts that we have, equal to giving someone heparin that we give without thinking about it all day long.
Right, right. That's great. That's great. To different question, different point for Adam. You know what we don't have is, and we have a preliminary study on this a couple of years ago from the ECOS data that we looked at time frame. What's the best time frame? Our receiver operator curve with 107, 120, something like that cases was less with ECOS was less than 72, preferably less than 24 for to get a procedure done, you get them on. So we don't have that impetus that we have with STEMI, for example. STEMI, 90 minutes, door to balloon, we run around. And that's something that's coming because it's been a big question of, do we treat these folks like STEMI, do them same day, middle of the night, whatever,
Mhm.
versus right now, which, I'm taking the stance that, and I can tell you, I can show you examples that when patients have come to me immediately, it's a different milieu versus somebody who's had 12, 14 hours of heparin, and I go back in there and there's a different milieu. So there's a procedural reason for me to do what I do, but I may not be correct long term when we start looking at RV function and mortality and things.
Let me ask you this: for is there any utility, or has this been looked at in terms of stage procedures? So maybe you front load by using half dose TPA and then following it up with suction thrombectomy. Any data there?
Are Yeah, no, there's a series coming forward out of New York. I believe it's the Columbia Boys. That group or one of the New York City groups has exactly that premise. They give, if someone is, at least tolerant of or be able to tolerate half dose lytics, they give half dose lytics the next day they go for angiography. So it's not unreasonable. Here locally, I believe another one of the other systems does exactly the same thing. And it's not an unreasonable strategy. I do think that you do expose risk in people who you may not want to. So I won't, as we talked about a 70, 80-year-old person, I won't give lytics to a 70 or 80-year-old person. I'll come and take
Right.
care of them mechanically because I think that's the right thing to do. But any of us have a PE that we can't get to a center, it's very reasonable to
Right.
give half dose.
Adam, can I throw up a question that's from the audience? I think that pertains
Yeah,
to this discussion.
Sure.
So for Han,
love
who's
this
been asking
question.
tons of great questions, by the way, but this is one of the great ones that he's putting out there. Leo, what do you think?
How do you
TPA.
manage?
So let's say you decide to go with a thrombolytic approach.
Mhm.
What do you do about the heparin? Are you starting it? Are you keeping it on while you're giving the thrombolytics? Do you hold it and then restart it? I think this creates a lot of confusion for people, and part of it's because study protocols have been doing it all different ways. So what say you?
I mean, I'm just going to give you the cardiology perspective. That TPA, when given, was given in the milieu of heparin. So a ACT 100, 80 and 18 was the initial dose, and then 80 units per kilo, 18 units per kilo per minute, and then thrombolytics could given over top.
On top
That's
of that,
yep, on top of that.
Yep.
yeah,
I think it gets really confusing because when you have a TPA protocol, a TPA stroke protocol, it very clearly says no heparin, right?
Yep,
But that is my practice. Is it maybe I pause it for the exact administration, but
yep,
the heparin's on immediately after. There
yeah,
right.
is no delay.
yeah.
Like very.
And while I can't quote for you the studies just offhand, there have been studies that have done the protocol that you just said: hold the heparin as you're administering the thrombolytic, and the rates of bleeding are less in those trials. So again, I don't know if we have a policy per se at our hospital, and this isn't to throw shade at our hospital, but I, I do personally hold the heparin,
Mm,
load it, give it, and then when it's time to get the thrombolytics, hold the heparin, give your thrombolytics, restart it, just to avoid that overlap. Again,
mm.
I don't know if there's evidence based, but we're only talking about a period of an hour or so.
Right.
Yeah.
But I think they may have some benefit. But being that we're in the neuro space, it's very interesting that they hold it. But we're again the only drug that we can give from a fibrinolytic standpoint without heparin is streptokinase, because that's such an activator of our anti-clotting cascade. That's the only time I've ever seen dramatic bleeding from TPA
Hmm.
was
Mm.
when we gave streptokinase for I was at the VA, and the VA is cost this is I'm really dating myself here. Adam wasn't. Adam didn't know how to use computer back then. It was so. But that's what their agent for lytic therapy was, and so I distinctly recall having to stop the anticoagulation, give the TPA, the streptokinase, excuse me, and that patient proceeded to bleed from several orifices. It was very, very impressive.
Oh,
So but I recall the TPA is absolutely necessary with heparin.
So let me ask Haney. I'm going to pick on you. So
Sure.
because I need the bedside intensivist view here. No, you should be in the view with me. I don't know what's on. You keep only putting me in the picture. So you have the patient. You've given them their massive PE. You've given them 50 milligrams of TPA. They do great. You come into round the next day, and they're hypotensive again. So what's the approach? And I know you're going to say echo first. And what are we looking for? What are you thinking about? Is the answer fluids? Is it more TPA? Is it diuretics? What's your thought process in that patient?
this is for me.
Yeah.
Yeah. Well, the first question is, why are they hypotensive? I know that sounds like an obvious question, but they also receive TPA. Have they been having some slow bleed? Did they get some
Mhm.
retroperitoneal bleed? Is there something there? But assuming I see what you're getting at, you're saying, no, this is a persistent clot, correct?
Correct.
Yeah, I mean, I've seen all of them. I've put the probe on patients, and their RV has been huge, and they've been getting fluids, and they've are compressing their LV, and I give them 40 of Lasix, and then all of a sudden they offload the RV, and everything gets better. I've seen patients that the clot's still there, and you need to give another 50 milligrams, and then
Mm-hmm.
I've seen patients who need vasopressors,
Right.
which is the next question: which ones do we pick? Um,
Well, I would say if you're within 24 hours, because my understanding and what I've always learned is that when you have somebody who has an acute PE or any clot, after like 24 hours, the cross linking has happened and the incremental benefit of giving thrombolytics is going to decrease anyway. And that gets back to Leo's point of when you want to do the suction, right? When it's
Right.
good formed clot, that's when you want to get in there and suction it out. And maybe that's a case to wait. So if I'm coming in 24 hours later and the person's decompensated, even if I wanted to give that person thrombolytics, I might not give that person thrombolytics. I might
Right.
lean on other things. If I'm within 24 hours, or let's say the person, I get the phone call, I give the TPA, I get a phone call 5 hours later that the person's not worse. I put the probe on, their RV still looks big. I, again, don't see a reason why that person shouldn't get another 50. They would still be well within the guidelines of
Right.
giving another 50. That would still be within a massive PE dose.
Right.
That being said, I think there's also opportunity to resuscitate that person. We can talk about the inotropes that you give them and the vasopressors, but that would be my strategy. Less than 24 hours, I would probably get them up to the full dose. Over 24 hours, even if they did have a clot, I probably would talk myself out of giving them more, because again, that's now I'm adding bleeding risk to that person, and there's a good
mhm.
chance that that clot has already
Yeah. I
organized a
mean,
little bit
this
better.
this is the interjection of mechanical, right? You've given 50. Hopefully, that the devices are on board. We can extract the clot if the RV is truly dysfunctional and our PAPI is low. We have opportunities to support the RV percutaneously. So that was one of the impetuses of getting RP Impella here was that should someone decompensate, we've had two cases that decompensated from their PEs that we've gone ahead and done RP post embolectomy. The other thought is, what do you think of someone who's not doing well? ECMO, ECMO for
Yeah,
the.
well, so first off, I think none of us had fluids. So I think most of us would not give fluids to these patients.
Correct. That is
And
correct.
I think what you said is really fascinating to me. And I don't know if the audience recognizes that to do a mechanical thrombectomy in a patient who's hypotensive is that's definitely pushing the boundary. Oh, are we paused? That's definitely pushing the boundaries a little bit because usually you don't rush those patients to the lab, right?
Sure, not normally, but again, case by case. If someone's hypotensive, received lytics, and they're still, when 2 to 4 hours later, I had a case with the quick care team, exactly the scenario. Someone received lytics outside hospital, arrived on our door, blown. The RV is still dilated and dysfunctional. Had just received them 4 to 5 hours ago, and we went in, we extracted. Little turnaround was impressive, hemodynamically. heart rate
Yeah.
came down, blood pressure rose, because I think you're just relieving that obstruction. And I think this is the setting at which you can, you've done every pharmacotherapy. I think every interventionalist will appreciate you've done everything you can to avoid rushing them to the cath lab, but this patient necessitates some mechanical support. So yes, normally I do love a 12, a certain amount of time, a day's worth of heparin, but this is a case where you've given thrombolytic therapy, and I think the next maneuver would be mechanical support.
Yeah. So how do you feel about mechanical support in the patient that just got lytics? So I'm not thrilled about putting arterial cannulas in someone that's got TPA infusing through them. Now the half life is pretty short, right?
Right. Correct.
Uh, but I think that that's probably not the scenario where you go to put an RP impella in or you put them on VA.
RP is not VA. RP, remember, is venous.
Yeah.
I still heavily respect the venous access and the venous side, but I think we have a comfort level now, large bore,
Yeah.
26, 28 French on the venous side, and it seems to work either IJ or groin. So, and we've had a fairly robust use of RP impella in our because we have such our referral base. And that's
Hmm.
from all you guys. We appreciate that. But having extracted, having given Halfdose lytics, and now we need some support because they still are not doing well, and we'll wait them out a little bit of time in the cath lab to see how they do. And I think putting an overnight of RP impella in someone who's gotten lytics and had a massive submassive to massive pulmonary embolism is a reasonable treatment strategy.
Let me ask the question: getting away from using thrombolytics, getting away from using suction. What's the data these days on surgical embolectomy, and which
Uh,
patients would you refer those people for first?
So I'll answer as the interventionalist. We partnership with our surgeons, and there are times when there's so much clot and I'm so obstructed, and it's such distal that I will bring them to the bedside and say, look, this is someone I really feel. So who is that? It is the massives who can be placed on, who they can put on hemodynamic CPS support to do their procedure. It is someone who's got clot in transit, of course. So they have their end game has been a large massive pulmonary embolism, but now also has clot that's somewhere else in their vasculature. They shy away from it because the procedural issues related to the surgery are high. You know that the surgical mortality is elevated, and I think it's a subset of population, not necessarily their procedural techniques. So it's a long-winded answer to you have to have a few, and you give them a call, and you make a decision together.
Yeah,
Historically speaking, they've asked me to extract first and see how the patients do. So, and that's been our safe strategy, and but that's resulted in some patients going to the OR the next day or once had a little bit of stabilization.
I think it depends on the center as well. I mean, that's kind of the answer for everything. But
Right.
I have been at centers where the surgeons are very good and they insist that their outcomes are very good, or they can do a mini thrombectomy where they just make a small little incision. They can grab something proximal and pull it out,
Mm,
and they say their outcomes are pretty good. So, but I think whenever you have a situation like that, it's probably in your best interest to at least make the phone call. Like if you're
mm,
unsure if the
Hmm.
person can get systemic thrombolytics,
100%.
and this maybe goes into the PERT team thing what we can talk about, but I do think it's sometimes we just say, no, they're not going to want surgeons aren't going to want to do it, but you don't know that until you call
That's
and
right.
ask.
That's right.
And
That's right.
you might have the surgeon who's on call that night that feels very comfortable doing it, and then it generates a discussion, or at least you have that as part of your sequence of a
That's right.
plan.
That's right. That's
I actually
exactly
think
right.
that's great advice just for everything. The patient with acute liver failure who's an alcoholic, and you decide not to refer them to a transplant center because you said they're drinking. I think that's probably. I ask the questions, and I'm happy to seem dumb just to go for it. So yeah, I put the burden on someone else to say no as opposed
Yeah.
to take it off the table.
Yeah.
Um,
Completely.
so two
Completely.
questions. First off, 100 milligrams. We give that to the coding patient, or does no one get 100 milligrams?
I'll let Leo. I have my answer,
Yeah.
but I'll let Leo
My,
answer.
I give to a coding patient, yes. 100 milligrams, full opportunity. Again, not I'm maybe it's my comfort level now with thrombolytics so that again we're quadruple the dosing, the amount of thrombolytics we give now are Cooper than when I first came years ago. So I think we're all getting a little bit more comfortable. Those are extreme situations. So I would give it, and then
Yeah.
be ready with considering if we don't get ROSC and hemodynamic stability, considering going on ECMO or
ECPR. Yep.
yeah,
Mhm.
ECPR. Exactly right.
Yeah, I agree with Leo. If you know the diagnosis of PE, like someone comes in and you have the diagnosis, or you do an ultrasound distally during the code and you find a clot and you're like, this is a PE, then I would give 100. But I
Mhm.
think the PEPET study from a few years ago, PEA, PETT, says that 50 is safe. And in that small trial, I think it was like 24 or 25 patients, like 23 of them had return of spontaneous circulation or yeah. And so it shows that it's very safe. And if you're unsure, but the story is leaning towards PE, one thing in codes in general, what I would say is that we always do this Hail Mary approach. Like everyone does the whole code, there's no perfusion to the brain, there's zero chance of survival. And then someone says, well, what's the harm if we just do something? That's the worst way to run a code. You want to
Completely.
run a code where you're saying we need to do everything up front. And
Yep.
so if
I
I
agree.
have a person who has a story that sounds like it could be a PE, but I can't exactly exclude it, that'd be the person I'd give 50 milligrams to right away. If I know they have a PE and they code, then yes, 100 milligrams.
Yep. I agree.
Great question.
I agree.
Great question.
And then the last thing, I think we mentioned vasopressors a little bit, and it's probably worthwhile just quickly mentioning it. So vasopressor of choice in the patient who's hypotensive from PE.
Me, Levo. I think it's the vasoconstriction. I don't think we have to use pure alpha, so therefore Neo comes off the table. My surgeons use epi, so just throwing
Hmm.
it out there.
I use
And I think
epi.
that
That's usually if
Yeah.
they're
yeah,
not that tachycardic, that's going to be the
that's
most
exactly what they use.
inotropy.
But
The most
yeah, epi,
inotropy. That's what I would pick.
yeah, epi or Levo, I think are what
Yeah.
most of us
And,
are using.
Yeah, I
and,
think either
and
one is absolutely fine. And if you need a second, like if you're waiting to do so, if you need a second, then you should be pulling up the TPA at the same time. But
Correct, correct,
if you're at that point, vaso would be my next one, only because
correct.
of pulmonary the pulmonary vasculature neutrality of it versus the systemic. That'd be a good pressor in that sense.
I
okay.
said, I said because of our surgeons, I covered CT surgery when I was a house officer. I still remember those days. They were, don't fear epi. Epi's tremendous.
Yeah.
So
Well,
epi for PEs, and I remember that. I remember
and
those
let me
days.
ask you as a cardiologist, because this is something that I learned when I was working in a cardiothoracic ICU. It's like my first job, is that if you have somebody whose RV is dysfunctional, like
Mm,
the only thing you could really do temporarily is give that RV a little bit of tachycardia, right? To
That's right.
increase the
That's
heart
right.
rate, to increase cardiac output. We
That's
don't
right.
think of that often for the LV, but if your RV is in trouble and you need to temporize things, giving a little tachycardia actually is helpful. So maybe epi would be something that'd be helpful.
As for our PE colleagues, yeah, no, maybe that's their rationale.
Mm-hmm.
All right, Adam and Haney, let me turn the tide on you, gentlemen.
Uh-oh.
So we
This
have
has never happened before.
a
We ask the questions.
Actually, Leo, it looks like time's
Yeah.
up.
oh,
So it
time's
was
up.
Leo,
great.
Time
it's
to
It
good
go.
was
having you
great
here.
seeing you.
Yeah,
And
I got this thing I got to do and dinner.
yep, happy
Yeah.
Valentine's Day.
No, I love this. I think I love talking about this. You can tell I'm passionate. You gentlemen know this, and your audience will get the sense that I've been in this space for a long time, for at least 10 years, and we're finally come to a point where we're trying to drill down some data. And that's my question: what I can show you today, based on our data, which is objectively obtained by in our institution, and we carry it and we march forward with it, that we improve your clinical improvement, and you get objective improvement of RV dysfunction, that it's sustained at 30 days and at 6 months. I have that. I can show you that with absolute certainty. What else would drive you to utilize the mechanical thrombectomy world to a greater extent? What else could we show to not dismiss the naysayers? I love the naysayers because it makes me think. It makes me step back and say, what are they seeing? What's their perspective? What else could we do?
Well, first question I'd ask you is how many patients are you seeing that you have the confidence now to say that for? And of course,
Uh,
these are all intermediate risk people we're talking about, right? So they're
correct,
all
correct.
intermediate risk. So how many patients are we talking about here?
So at Cooper, we have over 300 that we
Okay.
follow. And that's with their own data points. That was, you can imagine how many big this database is. You think of the Strike PE registry. That's 1,500. They're going to have exactly kind of those data endpoints, including, survival, but that's not their primary endpoint. What else could we show you?
The
So
control
I
group. That's the only
yeah.
thing I would add. The only other thing.
And we have that too. We have that too, because that was Dr. Dellinger, Dr. Treziak's question when they reviewed our data, is to say, you need a control group that was, submassive, not, on death's door, but submassive, that you felt that, pre-procedural, you put them on heparin and sent them on their way, and DOAC and sent them on their way. So
Yeah, I
what
mean,
else?
I would just need to see that. First off,
Mhm.
I should say that I am convinced based on the fact that the complication rate is incredibly low, and I've just seen anecdotally, but I've seen it at the bedside, the immediate improvement in oxygen requirements and hemodynamics and heart rate and symptoms and PA pressures. You see it when they go for clot extraction. So
Right.
I'm a believer from that. But to convince me in a long term, the problem, I'd have to see what that control group is, but
Mm.
you guys are selecting the people that are more likely to survive and have improvement and less likely to have chronic RV failure. And you're picking the people that are more likely to tolerate the procedure.
Right.
So unless it's totally blinded, I'm not sure how that, I would be hard to understand how that control group is a true control group.
Agreed.
Um, but I think functional outcome. I think that I would like to see, objective improvement in oxygen requirements and quality of life and functionality and 6-minute walk test. Those are
Right.
the things with a validated control group that would really convince me.
Okay. All right, that's great. I mean, our own control group is from 2016 to 2018. We didn't have
Okay.
these procedures, so they are true historical control of everybody walking through the door. So, all right, so an outcome measure, a functional outcome measure, we all agree that a mortality outcome measure would be unattainable.
Yeah.
Yeah, unattainable. So we have to use a surrogate, which would be just RV improvement, some other functional assessment. So, okay, all right.
And I
Everything's
And I would really love to see subgroup analysis of those that have like impaired PAPI or,
yep.
clear decrease in RV function versus those that just have RV strain, because I think that they're very different beasts.
The TAPSI group. Absolutely, yeah, absolutely.
Yep.
What is your RVL ratio? They're trying to break that into quartiles now. I did somebody today with an RVL ratio greater than 1.5, 1.7. So is it 1.1 you're fine, but at 1.2 you got to do something. So some risk analysis, risk stratification, which is still
Hmm.
going on today. So
And
cool. All right.
I'm glad you have the data on this. I'll say that, but I'm still interested in the group that's just a touch sicker. I'm still interested in that intermediate high risk group because let's face it, if we're talking about, let's call the group that we're talking about referring to here as intermediate low risk, right?
Okay.
Because right, I mean, fair. I mean, they're going to come
Yeah.
in, you're going to evaluate them. We're going to get an echo first. We're going to do all the things we need to do to make sure that we can get that person, and then we're going to take them. That's fine.
Right.
The group that still interests me is the group that scares everybody. And that's the
Hmm.
group that comes in 11 o'clock at night. You call someone on the phone, you say, hey, listen, this person's here. They're a little clammy, their troponins are elevated, their PESI score is high, but they're normotensive, or they had 1 or 2 episodes of hypotension, now they're stable, right?
Mm.
That's the group that I'm curious to see whether or not early intervention is going to help, because that person overnight is either going to do well and see you in the morning and get the catheter done, or they're going to acutely decompensate and then they're going to be too sick for that procedure. And then we're
Right.
going
Right.
to have
Right.
to act
And
on it.
need lytic therapy. Right. Right.
And that's the
Yeah.
group that's the
Yeah.
group that's interesting to me. And I think we'll get there. You have to,
Right.
anytime you're doing something new, you have to prove that it's stable in the stable
Correct.
people.
Correct.
But that's the group that I'm really interested in
Yeah.
seeing whether or not this is going to be helpful for.
No, thank you. I did. You said safety. That was the first thing I did when I first started all this. Is that we're comparing ourselves to heparin. And, heparin's hard to beat in some instances. Especially mortality wise. So I said we have to make sure that we're safe as we're charging forward, and it worked out for us. Great,
Yep.
great thought, Haney. That's exactly the group that we have to address. And I don't know how to figure those people out. Maybe lactate. I think Adam said lactate, and maybe that's the people we can restratify there.
How about the group that's intolerant to heparin too? I've been a big fan of those patients who you can't anticoagulate that have big central clots. Like, I don't know.
Yeah, no, no, wait. I have that series that actually we're presenting. That series, I think it's a small number. It's 30, 35, 40, something like that here at Cooper, and they do remarkably well. Then they get the IVC filter because obviously they're
Hmm.
intolerant long term, and but our outcomes with them have been excellent actually. And they remember they're on. I'm doing a device. I can't even give them heparin during the device, so
Hmm.
I'm really
Interesting.
my
Yeah.
hands are kind of tied.
Cool.
So, all
Should we take
right.
one or two questions from the audience and then we'll
Yeah,
let you
of
go?
course.
I mean, we ran
Of course.
long, but this is
Ah,
a
this is great.
conversation that Adam and I have been waiting for. We're so excited to have you here. And now that we have you here, we just want to ask you
Not
every
me, not me.
question. All right. So let me see. This is a question that we probably should have just asked you, but Randy has come through.
All right, very
Roll
nice.
a PERT at your institution. So we we kind of have a PERT team. Is that fair to say?
Correct. We've the PERT team was here at Coops is driven by mostly cardiology, a small smattering of IR and vascular surgery. That's really the PERT team. Excuse me, includes everybody: crit care, pulmonary, medicine, ER, pharmacy. But the procedural aspects is driven mostly by the IC. I think we're 80%. IR is 15 or 20%, and then another 5% vascular surgery. So we discussed cases. We agreed upon the criteria, the intermediate high, intermediate low risk criteria of who to proceed with. We agreed upon the utility of calling the surgeons to the bedside. So we have a two-tiered PERT approach. PERT for an average case that is not hypotensive and not looking unwell is the PERT C, we call it. That's when the cardiology consult gets involved. That's when the interventionalists get involved. That's when we call the vascular surgeons or CT surgeons if we're unhappy. And then the overall PERT is when everyone's phones goes off. And that's when the surgeons at the bedside. We have about 3 or 4 calls a year of the full PERT, and that's someone in the ICU or neuro ICU that is very, very ill, and they'll call a PERT alert, and they'll go off on my phone, and we'll all get on the phone together. And so it's data collection. It's buy-in from the groups that we all agree upon what patients should be looked at for lytic therapy versus mechanical thrombectomy versus surgical. And it's also a clinical tool to utilize for those sick people. So we've been very fortunate. Our PERT's been active for about 2 years. We are recently a member of the PERT Consortium. It used to be an expense, but now it's free. So I would advise anybody who's interested in the PERT to join them. They actually give you these kind of templates that we bastardized and put together ourselves. So I think it's helpful to get buy-in from the other groups. So our ER colleagues know we're looking for this. Our crit care colleagues know we're looking for these kind of patients, and we can do something for them. So they haven't sat for days with a PE in place.
Great. One more question before I let you go here. Let me see. Colton asks, let me get this out of the way here.
Mm-hmm.
Can you guys read that? Okay. So let's say the patient presents 48 hours after big RV. What do you do?
RVL ratio is 1. This is barely elevated. So I think that fulfills the ECOS data, right? That was the initial RVL greater than 1 was considered the opportunity. 0.9, excuse me, greater than 0.9 was considered the opportunity to help them. I don't know. That's a tough one. Hemodynamically stable. I might want to see the clots. I might want to see the CAT scan and make additional risk stratification. You said the RV was normal. RV was dilated, but the function was not discussed. So maybe go back to the echo discussion. The 60/60s, the TAPSI. We probably has a McConnell sign, I'm sure, but some of those echo criteria that also tell us that the RV is straining.
Gotcha.
So I would look at that. So availability, is it very, very distal that I'm not going to be able to actually grab with a catheter, that it's central and proximal, that allows us better heparin, thrombectomy, heparin, and lytic opportunities. Something like that. That's how I would approach it.
Yeah, I think the fact that there's so many factors just lets you know that this is not just a binary decision. And I'm guilty of it too sometimes. I just want this answer to be easy. I just want to be like, do I do this for this person or not? But it speaks to the fact that right now with our level of data, these are not easy questions. And the more data points that you have, the closer you can get to a decision. And having a PERT team personally has been great, because before there was a PERT team, you have to take the decision. It's like hot potato. It's like you take it, you make the decision. You make the decision. The transferring hospital doesn't want to make the decision, so I have to make the decision. But having a PERT team distributes I don't want to say the risk, but distributes the decision making so that
Right.
you hear perspectives from different angles. And then
Correct.
ultimately, you're leaving that conversation with one or two potential treatment plans for this person that everyone has decided upon.
Yeah, shared decision making. I
Yeah.
completely agree. It's great. No, that's a great case. You kind of want the patient to declare themselves. I want them to be a little tachycardic.
Right.
I want them to be a little soft blood pressure. I'm like,
Sure.
done. But
Adam, you got anything else?
No, I'm good. I'm good. It was great discussion.
yeah, great discussion. When the more I learn, the less I know. Right. That's that's what we're all discovering here. We don't know a lot about this disease. I blame pulmonary. They had this disease for many years and they do much with it. I'm just kidding. I'm just kidding. They're not here to defend themselves. So no, it's great. I mean, they're our partners. Here at Coops, they're great. I mean, they see all these folks and follow up for us. They want to do that. They also want to
Right.
be involved and try and pick up those CTEP patients. So I think it's a win-win. The patients are the greatest winners because they get a full multidisciplinary approach and hopefully great questions to answer in the future.
That's a great place to end right there, Leo.
I think so too.
Thank you so much. We were really psyched to have you on, and this was a great discussion. If you have any more questions, even though you might be watching this on replay, please drop it in the comments, and we'll pass it along to Leo, and we'll get it back to you. But Leo, thanks for joining us, and we'll
My
get you
pleasure.
on another time to talk about something else.
That'd be great. Coronary artery disease, that old habit. It's all old hat. Bye.
Cat them all.
Enjoy your night, everyone. Take care.
Thanks, Leo. Have a good one.
Goodbye.
That was awesome, Adam. We've been waiting for that
good.
one. That's been a good one. Yeah.
Yep.
I think what I take away from that is that I sort of said it already, that it's just you can't get binary answers for this disease. It's a spectrum depending on when you meet the patient, how they're presenting, how they've been resuscitated. Maybe they've been under resuscitated, maybe over. All these play into the decision of what you're going to do for that patient. What are your thoughts leaving that conversation?
Yeah, I think it's just such an undefined group of patients that I think those that are super sick, we know. I think those that are not sick, we know. And everything in between is just, I just think it's too heterogeneous for us to really know what to do with them.
Mm-hmm.
I know that I think we should be more brave about systemic lytics, probably. I think that we didn't talk too much about complications, but they're so low that if you have the opportunity, I think, to do suction thrombectomy, I think it makes sense. And then I think we should also really talk about where the clot is. We didn't get into that. It was mentioned several times, but a lot of these patients I see that come from outside hospitals have distal clots that can't even be intervened on.
Right.
And that is such an important part. But yeah, no, I thought it was really great. And I
think that's what's going to happen over time is now we're opening up our aperture and finding these patients and knowing that it's a specific population, we're going to start finding these specific phenotypes of patients. And, maybe we're saying intermediate low risk, intermediate high risk. Maybe we start classifying it by the anatomy or that becomes part of the scoring system. But now that we are aware of this thing and starting to study this population of patients, these are questions that will probably be asked more often and we'll have much more clarity. It's going to be one of those situations where when we're about to retire, we're just going to look at the medical students and like, oh, it's so easy for you. You just put it into a calculator and you pop it out. We had to make decisions.
Yeah.
And maybe that's what we're dealing with.
We didn't even talk about where do these patients, where do you watch them? Because all these submassive do not need the ICU, right? We've all seen them. They're sitting there eating their cheeseburger, watching the game with the submassive PE, waiting for clot extraction.
Right.
And it's hard. It's really challenging to know who's going to do poorly and who's not.
Yeah. Well, maybe the data set that Leo's talking about will come out and show that these patients, they do well despite whatever you do. Maybe that's another, kind of monitoring them. If there's no hemodynamic compromise, you can legitimately say, well, those people can go to an intermediate level care, maybe a regular telefloor just to watch them and everything will be all right. Lots of questions, Adam. Very few answers.
So we should say two things. Like and subscribe. We haven't said that yet.
Oh, thank you for reminding me.
Dude,
like and subscribe.
Nailed it.
Nailed it.
And then what are we talking about next? I guess we don't know.
We don't know.
I think
we don't know.
We have a goal to get back on the regular.
Yes.
So We're going to look at our
2023,
schedules.
lot more. So let me tell people what we've been discussing. So a few things. We're going to be doing this more regular. We're also going to be doing a lot more Instagram lives for the times that we just can't get to the studio and have a guest. People really like when we do lives together. They ask a lot of questions. The attendance is very, very high. And that's just a testament to the fact that a lot of people are just on Instagram, and that's okay. We'll be doing a lot more of that. We're also going to start rolling out in spring, maybe towards summer, the live shows, which is what this was always intended to be. We're going to start doing them live. We're going to be doing it locally in Collingswood, New Jersey. Lots of details coming out, but we'll have a live show. We're going to invite you. If you're in the neighborhood, you're just going to come on down and be part of the live audience, and we're still going to be streaming it out to everybody. So stay tuned for that.
Yeah. We've been talking about journal clubs. We've been talking about maybe doing a journal club kind of venue. We've been talking about a lot of different formats that same concept. Just
be together, be live, you know, and I think it's long overdue that we sort of get social again and do this again. So we'll be doing that. And again, if you're living across the ocean, don't worry, we're still going to be broadcasting it just the way it is. But Adam will be right over here, and then you will be over there. And then the final thing that I'll tell you is people have been DMing me asking for more content. They enjoy the show. They appreciate it. And I've been doing a membership group where we put content up every month. You get a bunch of lectures. There's actually a podcast that I do. I'm going to be inviting Adam on it soon. But if you're interested in that membership group, there's a link in the show where you can click on. It's less than a price of coffee per month. It basically just covers the keeping the lights on for that membership group. Check it out if you want a little extra content. If you don't like it, cancel it. If you don't feel like doing it, don't worry. We're not going anywhere. We're still doing lots of free content for you. But I did want to give people the opportunity to get something else if they just want a little bit more content. So with that, Adam, it's good to see you again. We are going to announce very soon what our next show is going to be so people can stop popping on their calendars. Yeah?
Very good.
All right, everyone. Be safe out there. I'm sorry if you were rooting for the Eagles. If you're a Kansas City fan, we hate you. And enjoy your parade. See you later.
Bye, everyone.